Hello students. Welcome to Assessment of the Gastrointestinal System. We are entering this area in the semester. There's going to be a lot of chapters, but I think this is one of the most important topics in general in healthcare. So the key terms we are going to review are amylase, bruit, colonoscopy, endoscope. We're going to talk about endoscopic retrograde cholangiopancreatography, ERCP, esophagogastroduodenoscopy, EGD, WIAC-based fecal occult blood tests, GFOBT, lipase, sigmoidoscopy, steatorrhea. So the priority concepts for these chapters are nutrition, elimination, pain, and let's start with a video of the gastrointestinal, the digestive process, which is very important to start getting into the concepts of this chapter. Okay, let's watch this video.
Our digestive system is made up of a series of organs that allows our body to get the nutrients and energy it needs from the food we eat. Digestion starts in the mouth, where chewing and saliva breaks down food so it is more easily processed by your body. Once you swallow, the food enters the esophagus, which is a muscular tube that connects the pharynx, or throat, to the stomach. The esophagus contracts as it moves food into the stomach. A valve called the lower esophageal sphincter, or LES, is located just before the opening to the stomach. This valve opens to let food pass into the stomach from the esophagus, and it prevents food from moving back up into the esophagus from the stomach. Next is the stomach, an organ with strong muscular walls. It holds the food and mixes it with acid and enzymes that continue to break the food down into a liquid or paste. Almost 20 feet long, the small intestine, also called the small bowel, is the workhorse of the digestive system. It will continue to break down food with enzymes released by the pancreas and bile released from the liver. It is made up of 3 segments: the duodenum, which continues the breakdown of food, and the jejunum and ileum, which are mainly responsible for the absorption of nutrients. Aiding the digestive process is the pancreas. Among its other functions, the pancreas helps digestion by producing digestive enzymes and secreting them into the duodenum, the first segment of the small intestine. These enzymes break down protein, fats, and carbohydrates. The liver is another organ with many functions. Its main responsibilities in the digestive process are to make and secrete bile, and to process and purify the blood, which contains newly absorbed nutrients that are coming from the small intestine. Bile has 2 main purposes: to help absorb fats and to carry waste from the liver that cannot pass through the kidneys. Bile made in the liver travels to the small intestine through bile ducts. If the bile isn't needed immediately, it is stored in the gallbladder, which is a pear-shaped reservoir located just under the liver. The gallbladder sends this stored bile into the small intestine to aid in the digestion of food. Next along the journey is the colon, or large intestine. It is a 5 to 7 foot long muscular tube that connects the small intestine to the rectum and is responsible for processing waste so that defecation is easy and convenient. The rectum is an 8-inch chamber that connects the colon to the anus. The rectum receives stool from the colon, sends signals to the brain if there is stool to be evacuated, and holds stool until evacuation can happen. The last part of the digestive tract, the anus, consists of pelvic floor muscles and 2 anal sphincters, internal and external. Together, their jobs are to detect contents in the rectum, determine whether the contents are liquid, gas, or solid, and then control when stool should or shouldn't be excreted from the body. It's useful to understand the digestive system and the role it plays in your overall health and well-being. Knowing where to go when conditions of the digestive system affect your health and well-being is just as important. The University of Michigan Health System is home to one of the largest digestive health and liver disease programs in the country, providing prevention, diagnosis, and treatment of diseases involving the gastrointestinal tract and liver.
Thank you to the University of Michigan. We had a great review of the gastrointestinal system, also well known as the second brain in our body. And in the future lectures, so probably we are going to start discovering why they call the gastrointestinal the second brain. Maybe in this lecture and a little bit in the next lectures. So although the gastrointestinal tract is continuous from the mouth to the anus, it is divided into specialized regions, right? The mouth, the pharynx, the esophagus, the stomach, and a small and large intestine, each perform a specific function. In addition, the secretion of the salivary, gastric, and intestinal glands, liver, and pancreas empty into the GI tract to aid digestion. So here we have a nice graphic of the gastrointestinal that starts in the mouth and ends in the anus, right? And here we have the wall of the GI tract. The functions of the GI tract include secretion, digestion, absorption, motility, and elimination. So before food can be absorbed, it must be broken down to a liquid called chyme. Digestion is the mechanical and chemical process through which complex foodstuffs are broken down into simpler forms that can be used by the body. During digestion, the stomach secretes hydrochloric acid, the liver secretes bile, and digestive enzymes are released from accessory organs, aiding in food breakdown. So let me make a parenthesis here. One of the biggest problems in healthcare in general, one of the biggest problems in human health happens to be based on deficiency of hydrochloric acid, or lack of bile, or lack of digestive enzymes. So these can generate problems in the microbiota of your digestive system, causing different diseases, okay? So all the way from malabsorption to iron deficiency to brain issues, mental state issues, because of the problem in the gastrointestinal, and especially because of this factor that I just mentioned: hydrochloric acid, the lack of bile, enzymes, and microbiota issues. After the digestive process is complete, absorption takes place, and the nutrients produced by digestion are moved from the GI tract into the body's circulatory system for use. And that's good to know. The oral cavity, the mouth, includes the buccal mucosa, lips, tongue, hard palate, soft palate, teeth, and salivary glands. So swallowing begins after food is taken into the mouth and chewed. Saliva is secreted in response to the presence of food in the mouth and begins to soften the food. Saliva contains a specific mixture of products, including salivary amylase and salivary lipase. So we are going to hold that thought in those enzymes, the amylase and the lipase, in the saliva, okay, that breaks down carbohydrates and lipids respectively, meaning amylase is going to break down carbohydrates and lipase is going to break down lipids, okay? So remember those two. In the esophagus, this is a muscular canal that extends from the pharynx, the throat, to the stomach and passes through the center of the diaphragm. Its primary function is to move food and fluids from the pharynx to the stomach. And at the upper end of the esophagus is a sphincter referred to as the upper esophageal sphincter. When addressed, the UES, the upper esophageal sphincter, is closed to prevent the movement of air into the esophagus during respiration. The portion of the esophagus just above the gastroesophageal junction is referred to as the lower esophageal sphincter. When at rest, the low esophageal sphincter normally closed to prevent reflux of gastric contents into the esophagus. So if the LES, the low esophageal sphincter, does not work properly, the gastroesophageal reflux disease, GERD, can develop. And we are going to watch another video to have this concept clear about the sphincter and how this, is it a video or, oh no, it's a graphic. So here you can see that we have, I hope you can see, we have here the trachea is the one here in front, and behind the trachea, this tube here is the esophagus. Okay, so that is for you to understand the location of the trachea, the esophagus. Okay, so when we talk more in deep about the GERD and all the conditions, you can understand that sometimes we want to prevent aspiration, right? Okay, so the stomach. Oh, we have another video here about GERD. Okay, by the Cleveland Clinic. Okay, let's watch this one. GERD.
Gastroesophageal reflux disease, or GERD, is a condition that causes the burning sensation known as heartburn. When you swallow, food passes down your throat and through your esophagus or food tube to your stomach. A muscle called the lower esophageal sphincter controls the opening between the esophagus and the stomach. This muscle remains tightly closed except when you swallow food. When the sphincter fails to close, the acid-containing contents of the stomach can travel back up into the esophagus. This backward movement is called reflux. When stomach acid enters the lower part of the esophagus, it can produce a burning sensation commonly referred to as heartburn. Several factors might explain why this reflux action occurs. The most important are the following: the position of your body after eating. An upright posture helps prevent reflux. The size of the meal. Smaller meals reduce reflux. The nature of the foods you eat and drink. Certain substances that irritate the esophagus or weaken the sphincter can cause reflux.
Thank you so much. So we are clear on the location of the lower esophageal sphincter, and we talk about the we talk about the oral cavity, we talk about the esophagus, and right now we are gonna start talking about the stomach. The stomach is located in the middle and left upper quadrant of the abdomen and has three functional regions: the fundus, body, and the antrum. Okay, so the fundus is the area nearest to the cardia. The main area of the stomach is referred to as the body of corpus. The antrum pylorus is the distal lower portion of the stomach and is separated from the duodenum by the pyloric sphincter. Parietal cells lining the wall of the stomach secrete hydrochloric acid, whereas chief cells secrete pepsinogen, a precursor to pepsin, a digestive system that we're going to speak about this later when we talk about diabetes. Parietal cells also produce intrinsic factor, a substance that aids in the absorption of vitamin B12. Absence of intrinsic factor causes pernicious anemia, and we discussed this during the segment of the hematologic conditions. The stomach misses or churns the food, break apart the large food molecules and mixes them with gastric secretions to form chyme, which then empties into the duodenum. The intestinal phase begins as the chyme passes from the stomach into the duodenum, causing distension. Now the pancreas. The pancreas is a long and flat pear-shaped organ that lies behind the stomach and extends horizontally from the duodenal loop to the spleen. Two major cellular bodies, exocrine and endocrine, within the pancreas have separate functions. The exocrine part consists of cells that secrete enzymes needed for digestion of carbohydrates, fats, and proteins, proteases, amylase, and lipase. So those are the enzymes of the pancreas, right? Remember salivary lipase and salivary amylase that I told you, hold that thought? Some, where is it? So I'm lost already. Okay, some amylase and lipase can be found in saliva and the stomach. So it's not only in the pancreas. You can find these enzymes on the salivary and the stomach. The endocrine part of the pancreas is made up of the islets of Langerhans, with alpha cells producing glucagon and beta cells producing insulin, as well as delta and pancreatic peptide cells. The hormones produced are essential in the regulation of metabolism. Okay, liver and gallbladder. The liver is the largest organ in the body, other than the skin. I would say, in my opinion, is one of the most important organs in the body. Probably in the second place after the heart, because of all the functions that the liver has. And it's located mainly in the right upper quadrant of the abdomen. The right and left hepatic ducts transport bile from the liver. The liver performs more than 400 functions. That's what I consider is, sometimes I think is even the most important organ in our body. But you cannot live away, you cannot leave the heart out of the first place, right? But it's just my opinion. In three major, so it's performing more than 400 functions in three major categories: storage, protection, and metabolism. It produces bile, which facilitates the digestion of fats and lipids. It stores main minerals and vitamins such as iron, copper, fat-soluble vitamins like A, D, and E. And I think we are missing the K. See here, vitamin K is also fat-soluble, and water-soluble vitamin B12. So the liver also detoxifies, on top of everything else, potentially harmful compounds, drugs, chemical, alcohol. Therefore, the risk for drug toxicity increases with aging because of decreased liver function. Please remember this: the liver also detoxifies potentially harmful compounds, drugs, chemical, alcohol. Therefore, the risk for drug toxicity increases with aging because of decreased liver function, and that's good to know. The liver function in the metabolism of proteins that are vital for survival. It breaks down amino acids to remove ammonia. So when we talk ammonia, we talk about the liver, and that's good to know, which is then converted to urea and is excreted via the kidneys as urine. It synthesizes several plasma proteins, including albumin, prothrombin, and fibrinogen, and the list goes on and on. I don't finish talking about the liver. That's why sometimes I truly believe the liver is the most important organ in our body. The liver's role in carbohydrate metabolism involves storing and releasing glycogen as the body energy requirements change. The organ also synthesizes, breaks down, and temporarily stores fatty acids and triglycerides. So remember, ammonia is related to the liver, right? And what else I want you to remember from here? Drug toxicity increases with aging because of decreased liver function. Okay, so we have a nice picture here: anatomy of the pancreas, liver, and gallbladder. I want to say something else about the liver. When we sleep, the only organ that is awake is the liver. And the liver is kind of doing accountant. It's like an accounting, right? Accountant, right? So it's doing the job of an accountant. The liver is telling us, okay, vitamins go to the right, minerals to the left. What we got today, we got 20 milligrams of, I don't know, vitamin A. This go here. How many protein we got today? We got 3 grams of protein. Go there. So while we are sleeping, the liver is organizing everything in the body. Having said that, when we work overnight in the night shift, our circadian rhythm is affecting the liver function, okay? Because we are not sleeping, so the liver cannot perform the activities that I just mentioned. So think about that. Think about how working overnight can affect our health and liver health and performance in general. Okay. The liver forms and continually secretes bile, which is essential for the breakdown of fat. Bile is secreted into small ducts that empty into the common bile duct and into the duodenum at the sphincter of Oddi. However, if the sphincter is closed, the bile goes to the gallbladder for storage. Gallbladder is a pear-shaped bulbous sac that is located underneath the liver. The gallbladder collects and concentrates and stores the bile that has come from the liver. It releases the bile into the duodenum via the CBD when fat is present, which CBD means common bile duct. Okay, small intestine. The small intestine is the longest and most convoluted portion of the digestive tract, measuring an average to 9 to 16 feet in length in an adult. It is composed of 3 different regions. Remember DJI. Do you know DJI? Your duodenum, jejunum, and ileum. That's a good way to remember the 3 parts of the small intestine. The ileocecal valve separates the entrance of the ileum from the cecum of the large intestine. Again, the ileocecal valve separates the entrance of the ileum from the cecum of the large intestine. And believe it or not, some students that I talk to, not in this course, but when I am precepting some people in the clinic, they believe that the ileocecal valve, they confuse the ileocecal valve with the appendix, and it's not. Okay? Please, ileocecal valve separates the entrance of the ileum from the cecum, which is the entrance of the large intestine. The small intestine has 3 main functions: movement, mixing and peristalsis, digestion, and absorption. Intestinal enzymes aid the body in the digestion of protein, carbohydrates, and lipids. Let's go to the large intestine. The large intestine extends about 5 to 6 feet in length from the ileocecal valve to the anus, and it begins in the cecum, a dilated pouch-like structure that is inferior to the ileocecal opening. I am repeating this over and over because I don't want you to get confused with the appendix. At the base of the cecum is a vermiform appendix, which recent theories have tied to the maintenance of intestinal immunity. The large intestine then extends upward from the cecum as the colon. The colon consists of 4 divisions: ascending, transverse, descending, and sigmoid colon. Easy. The sigmoid colon empties into the rectum. The last 1 to 1.5 inches of the large intestine are called the anal canal, which opens to the exterior of the body through the anus. The large intestine functions are movement, absorption, and elimination. That's it. Nothing else. Movement, absorption and elimination, and basically the absorption of water. So if you don't move your colon, okay, there is no absorption of water, therefore there is no elimination. Movement in the large intestine consists mainly of segmental contractions, such as those in the small intestine, to allow enough time for the absorption of water and electrolytes, basically fluids, right? In addition, peristaltic contractions are triggered by colonic distension to move the contents toward the rectum. So the large intestine is going to move, it's going to contract, at the same moment it's going to absorb the water and electrolytes, and that hard residual portion is going to go for elimination, where the material is stored and the defecate occurs. Okay, absorption of water and some electrolytes occur in the large intestine to reduce the fluid volume of the chyme. This process creates a more solid material, the feces, for elimination. Good. Let's go to GI changes associated with aging. I strongly suggest you to review this table and try to take a picture in your brain, not because of the test, but because of NCLEX, and because the most important is that you need to identify all these processes in your family members. That's your first line of care, right? The family. So the physiologic change is atrophy of the gastric mucosa, leads to decreased hydrochloric acid levels. So I told you this is one of the biggest health concerns in general, because this is going to decrease the absorption of iron and B12, the hydrochloric acid in the stomach, okay? Decreasing the absorption of iron. You can take all the iron you want, but if you don't have enough hydrochloric acid, the iron is going to go somewhere else. The same thing with vitamin B12 and proliferation of bacteria, okay? Atrophic gastritis occurs as a consequence of bacterial overgrowth. As I told you, the microbiota is going to be in balance, the good and the bad. Next, peristalsis decrease and nerve impulses are dull, right? So we have a decreased sensation to defecate and resulting postponement of bowel movement, which leads to constipation and impaction. Distension and dilation of pancreatic duct change. Calcification of pancreatic vessels occur with a decrease in lipase production. So steatorrhea, which is fatty stool, occurs because of decrease of fat digestion. Steatorrhea, fatty stool, occurs because of decreased fat digestion. And this can lead to the previous concept, constipation and impaction can lead to paralytic ileus, which I mentioned in the previous class, and some students got confused with ileum. No, paralytic ileus is is when there is no peristalsis, with the paralysis of peristalsis, right? It's called paralytic ileus. It means that the muscles of nerve signals that trigger peristalsis have stopped working and the food in your intestines isn't moving. Okay, let's go back to steatorrhea, which is fatty stool, occurs because of decreased fat digestion. And also we have decreased enzyme activity, depresses drug metabolism, which leads to accumulation of drugs, possible to toxic levels. And that's good to know. This part here, drug metabolism, which leads to accumulation of drugs, possibly to toxic levels, and also steatorrhea. Okay, you need to know your concepts related to GI. Intestinal microbiota abnormalities occur during the aging process. Dysfunctional microbial activity contributes to anorexia and subsequent undernutrition. So as I told you, all the factors like deficiency in hydrochloric acid, lack of bile production, this imbalance in microbiota can contribute to different problems in the GI system, which in fact can translate to problem in the brain and the overall health. And we're going to discover this a little bit in this chapter and then in the future chapters, okay? Now, hepatic cells, drug toxicity relationship is something that I want you to remember, please. Assessment, patient history. General history, the purpose of the health history is to determine the events related to the current health problem, ask questions about changes in appetite, weight, and stool, determine the patient's experience with pain, if that is a concern. Collect data about the patient's age, gender, and culture, and we have an NCLEX examination challenge 45.1. Which of the following GI findings in the older adult would the nurse associate with aging? Select all that apply, and the answer is elevated bacterial growth, right, because of the imbalance in the microbiota, and retention of drug products. So the rationale here is the normal growth of bacterial flora in the older adult can become disrupted over time, contributing to inflammatory processes and reduction of immunity. Bacterial overgrowth occurs as a result of decreased hydrochloric acid in the stomach, and then decreased liver function and enzymatic changes results in retention of drug products. So finally, ask whether the patient has traveled outside the country when you are doing the assessment, right? If he traveled outside recently or has been camping near lakes and streams in any location. And this information may provide clues about the cause of symptoms such as diarrhea. Okay. Nutrition history is very important to inquire about any special diet and whether they are any known food allergies. Ask the patient to describe the usual foods that are eaten daily and the times at which meals are taken. Ask if there is a personal or family history of lactose intolerance. It's very important. Assess for anorexia, changes in taste, and any difficulty or pain with swallowing, which we know is dysphagia, because this can be associated with esophageal disorders. Recognize that one of the symptoms associated with COVID-19 is loss of taste. Ask about abdominal pain, nausea, vomiting, dyspepsia, heartburn, unintentional weight loss, because some GI cancers may present in this manner. Assess for alcohol and caffeine consumption, because both substances are associated with many GI disorders, such as gastric and peptic ulcer disease. You have a best practice for patient safety and quality care box. Basically questions for GI health history. Some of them we mentioned already. Important always to ask about what medication the patient is taking, vitamins, minerals, herbal supplements, difficulty chewing or swallowing, and how is the pattern of bowel elimination. In functional medicine, we believe that the most important of the gastrointestinal health is the pattern of bowel elimination. So the way your bowel movement is, the color, the shape is telling us how your health is, basically. Okay? And we believe that everything starts in the gastrointestinal system, that all the diseases in the body starts in the gastrointestinal. The patient's socioeconomic status may have a profound impact on nutrition. They may substitute less expensive and less effective over-the-counter medication or herbs for prescription drugs. So culture and spirituality. In terms of nutritional observances, we have to consider spices or hot peppers used in cooking, which can aggravate or precipitate digestion. Note spiritual observations such as fasting or abstinence and whether they may have an impact on the patient's nutrition, health, or symptoms that are occurring. We also want to consider family history and genetic risks. For example, familial adenomatous polyposis is an inherited autosomal dominant disorder that predisposes the patient to colon cancer, and there are tests that can be done in these regards. Okay, so the patient can request the PCP to order this genetic test or the gastrointestinal specialist, right? Current health problems also ask about the location, quality. Remember your old cards mnemonic to assess for all these problems. Whatever I'm gonna mention right now are the most important factors to assess in gastrointestinal changes in bowel habits. As I mentioned before, the bowel bowel movement pattern is extremely important. If you see blood, you know there is some type of bleeding coming from, depending on the type of blood, if it's dark, if it's fresh blood, why this bleeding is occurring. Maybe there is an opening in the mucosa, maybe the patient is having Crohn's disease, diverticulitis, maybe there is ulcers. These ulcers is caused by different types of nutritional habits. So the list goes on, and everything is being told by the bowel movement pattern. Okay, so you want to assess for the consistency of the feces, the diarrhea, constipation, frank blood or tarry stools, abdominal distension, and the list goes on and on. So I gave you in the supplemental file a Bristol stool chart, okay, that you can check. Also assess for normal weight, weight gain or loss, timing of significant weight gain or loss, changes in appetite. In terms of blood, I would like to say that frank blood reveals problems in lower colon. If it's bright red, it's in the lower colon, in the rectum, in the anus. If it's tarry, black stool, also known as melena, the issues is in the upper digestive system. So the rationale is that the blood that is darker means that travel a long way. So that's why we are talking about the upper intestinal, the upper digestive system, right? So it's melena, is dark, is black stool. This blood travels the long way to get to the colon. It's gonna be black blood. So if bright red, is in the lower part of the colon, right? Steatorrhea, some pancreatic enzymes diseases, and we know that steatorrhea means fat in the stool, is going to be related to pancreatic diseases, cystic fibrosis, kidney damage or failure, liver damage, etc., etc., etc. Crohn's disease, celiac disease. So pain is a common concern of patients with GI tract disorders. Abdominal pain is often vague and difficult to evaluate. So you have here another mnemonic. PQRST may be helpful in conducting a pain assessment. Precipitating or palliative factors is the P. The Q is going to be quality and quantity. R, region or radiation, S, severity scale, at T, timing. So as you can see, when I mentioned the different characteristics of the blood in the stool, you saw that I mentioned a lot of conditions, right? So that's what I'm telling you. The pattern in your bowel movement is telling us basically everything. When we have a patient with steatorrhea and Crohn's disease, and we can, let's say we do the test and the patient is having Crohn's disease, so you know that we need to conduct genetic testing. Probably we know the origin of the patient. We already know by the origin of the patient and the genetic, we are going to define the nutritional habits, and too many things can be described by the pattern of the bowel movement. Physical assessment, signs and symptoms in preparation for assessment of the abdomen. Ask the patient to empty the bladder and then to lie in a supine position with knees bent, keeping the arms at the sides to prevent tensing of the abdominal muscles. And I'm sure you will told how to do your physical assessment for the abdominal area in your open lab. And nurse generalists perform inspection, auscultation, and light palpation. And the healthcare providers, meaning the PCP, the nurse practitioners, perform inspection, auscultation, deep palpation, and percussion. If appendicitis or an abdominal aneurysm is suspected, palpation is not done. Avoid auscultating or palpating any pulsating abdominal mass. This can be a life-threatening abdominal aortic aneurysm. Okay, so in terms of inspection, we are going to use the Z method because we are going to go from the right upper quadrant to the left upper quadrant, and then we are going to go to the left lower to the right lower quadrant. So that's the Z method. If areas of pain or discomfort are noted from the history, they are cautiously assessed last in the examination sequence. This sequence should prevent the patient from tensing abdominal muscle because of the pains, which can make the examination difficult. Inspect the skin, especially overall asymmetry of the abdomen, discoloration of or scarring, abdominal distension, and bulging flanks. So here we have this graphic, which I really love, and I think this is a great improvement from the 10th to the 11th edition. So we can see that most of the people think that the stomach, for example, is in the middle of the abdominal area, and it's not. It's most of it in the left upper quadrant, and some part just to remain near kind of the pyloric area is on the right upper quadrant. And then you have in the right upper, you have most of the liver. You are going to have also the gallbladder, right? And you have part of the transverse colon, which extend to the left upper quadrant as well. And then in the lower quadrant, you have the beginning of the ascending colon, the ovaries, the ileocecal valve, and the appendix, and the cecum. And okay, so we are going to assess also for subcutaneous fat, noted, location, size, and description of any pressure injuries. Observe the contour and symmetry of the abdomen, which can be rounded, flat, or distended. So, nurses, safety. Peristaltic movements are rarely seen unless the patient is thin and has increased peristalsis. If these movements are observed, note the quadrant of origin and the direction of peristaltic flow. Okay, report this finding to the healthcare provider because it may indicate an intestinal obstruction. Yes, because if you notice, after the small intestine, we have the ascending colon and then the transverse colon, right? So if there is an intestinal obstruction, the pathway to the sigmoid colon could be in the other way. So probably the peristalsis is going to be, instead of being to the left, okay, because the ascending column goes through the right lower quadrant to the right upper quadrant, transverse colon, right to left, and then down to the left. But when there is intestinal obstruction, everything goes in the other way. Okay, so I hope you can stop rewind and try to follow me with your vision of what I am describing in the sense of how the bowels move, okay, in the sigmoid colon direction. Okay, so this is good to know. NCLEX alert in terms of intestinal obstruction. Observe abdominal movements, including the normal rising and falling with inspiration and expiration. Occasionally, pulsations may be visible, particularly in the area of the abdominal aorta. Another safety priority, that's good to know, NCLEX alert. If a bulging pulsating mass is present during inspection of the abdomen, do not touch the area with hands or the stethoscope because the patient may have an abdominal aortic aneurysm, a life-threatening problem. Notify the healthcare provider of this finding immediately. Let's talk about auscultation. Vowel sounds are created as air and fluid move through the GI tract. They are normally heard as relative high pitch, irregular gargles with a normal frequency range of 5 to 30 per minute. They are characterized as normal, hypoactive, or hyperactive. They are diminished or absent after abdominal surgery or in the patient with peritonitis or paralytic ileus. So, peritonitis is the inflammation of the membrane lining the abdominal wall and covering the abdominal organs. Peritonitis is usually infectious and often life-threatening. It's caused by leakage of the hole in the intestines, such as from a burst appendix, and that's one of the reasons, right? Could be one of the reasons. Another reason, it could be a surgery and the sutures were not done really good, so that liquids are coming to the abdominal area, causing peritonitis. Let's review this sentence. They are diminished or absent. We are talking about the vowel sounds. Could be normal, hypoactive, or hyperactive. They are diminished or absent after abdominal surgery or in the patient with peritonitis or paralytic ileus, when there is no movement. The most reliable method for assessing the return of peristalsis after abdominal surgery is to ask if flatus has been passed within the past 8 hours or a stool has been produced within the past 12 to 24 hours. That's how you assess the return of peristalsis. Increased high-pitched vowel sounds, especially loud gurgling sounds, result from increased motility of the bowel, and it's called borborygmus, okay? These sounds are usually heard in a patient with diarrhea or gastroenteritis, or are heard above a complete intestinal obstruction. So you're going to hear high-pitched vowel sounds when there is a crisis in the bowel, right? In the gastrointestinal. So there is an increased motility. And also when there is a complete intestinal obstruction. So the movement cannot be performed. That's why these sounds are going to go back and forth. Auscultation of the abdomen is performed with the diaphragm of the stethoscope because vowel sounds are usually high pitch. So you place the stethoscope lightly on the abdominal wall, beginning in the right lower quadrant in the area of the ileocecal valve, where vowel sounds are normally present, and proceed with listening to other quadrants. So you start in the right lower quadrant, right? And as I told you, the ileocecal valve is not the appendix. So here you have the location of body structures in each abdominal quadrant and midline. We describe most of them. So in the right upper quadrant, you have most of the liver, you have the gallbladder, the duodenum, yes, head of the pancreas, hepatic flexure of the colon, and I want to, okay, we're gonna put a video right now about the stethoscope because this is something very important for you to remember.
Stethoscopes have two sides from which you can listen. The smaller side is the bell, and the bell is used for your lower frequency tones, like your heart sounds and for murmurs, things like that. And then your diaphragm, which is the larger side, is used for your higher frequency tones, like lung sounds and bowel sounds. Now you can use either one for blood pressure. It is sometimes recommended, especially for newer learners, that the bell is used for blood pressure. I personally like to use the diaphragm, so it's kind of each your own kind of thing. To use either one, you simply turn it at the end of your stethoscope. It has an audible click usually. I don't know if you guys can hear that, but I turn it to tell my stethoscope which one to turn on, right, and which one to turn off. And so this is actually something you've probably seen when you see like medical TV, right? The practitioner puts the stethoscope earbuds in, and then they tap on it, and that is actually a real thing, because you can tell which one is on, because obviously it would be really loud, and which one would be off, right? Some stethoscopes now have like a little indent or a colored circle, and that would help like indicate which one is on and which one is off, so that you don't have to do the tapping. But I find a lot of us still anyway tap just to make sure it's on.
Thank you so much, students. I strongly suggest you to review and to practice your skills because next semester you are going to have surprises. Please practice your skills. That's why I'm reviewing with you all these techniques of the stethoscopes. I keep asking you about basic concepts of nursing, right? You will have surprises before your graduation. I am not authorized to disclosure more information, but you're going to be tested and evaluated in everything. Okay, so keep an eye on this. Now, hepatic flexure of the colon is basically where there is the flexure between the ascending colon and the transversal, and then you have the splenic flexure of the colon is specifically where the colon flexure to become the descending colon from the transversal, right? So here you have more and more descriptions. You have in the midline, you have the abdominal aorta, which is coming from the heart and getting to the midline, and then bifurcates to the femoral arteries to the right and to the left. And also you have the uterus, if enlarged, in this midline, and the bladder. Then you have the cecum, the appendix, and in the right lower quadrant, and then the sigmoid colon in the left lower, and the ovary and fallopian tubes in both sides. Okay, so during auscultation also listen for vascular sounds or bruits over the abdominal aorta, the renal arteries, and the iliac arteries. A bruit heard over the aorta usually indicates the presence of aneurysm. If this sound is heard, do not percuss or palpate the abdomen. We are going to watch another video about the renal bruit, and the reason I'm doing this is because a life-threatening situation. Okay, so you need to know this.
In this video, you will see a demonstration of how to auscultate a renal bruise. A bruit is a whooshing sound as blood flows through a narrowed vessel, and in this circumstance it could be associated with narrowing of the renal artery, which is referred to as renal artery stenosis. So let's take a look at how to do this practically. You should first set up your stethoscope so that you're listening to sounds through the bell. This is because whereas the diaphragm of the stethoscope is more attuned to relatively high-pitched sounds, the bell is more sensitive to low-pitched sounds like bruits. You should auscultate 1 to 2 centimeters superior to the umbilicus and slightly lateral to the midline on each side. A bruit in this location may be associated with renal artery stenosis. So now that you know how to do this practically, let's listen to the sound of a renal artery bruit. If you learned something new from this video, please remember to like the video, subscribe to the channel, and leave me a comment in the comments section. I tend to reply to all questions that are asked. Thanks for watching.
Thank you very much. So the lady before, the one talking about the stethoscope, was saying that for high pitch you're using the diaphragm, right? And for low pitch you use the bell, and she refers low pitch as the hard sounds, right? But in this video you can see that also the bruit is considered a low pitch because you are not using the diaphragm, but you're using the bell of your stethoscope. Okay, palpation of the abdomen consists of two types, light and deep. Nurse generalists perform light palpation. The technique of light palpation is used to detect large masses and areas of tenderness. So you leave the deep palpation for the healthcare provider or their practitioners. Percussion may be done by the healthcare provider to determine the size of solid organs, to detect the presence of masses, fluid, and air, and to estimate the size of the liver and spleen. The percussion notes heard in the abdomen are termed tympanic, the high-pitched, loud musical sound of an air-filled intestine, or dull, the medium-pitched, softer, thought-like sound over a solid organ such as the liver. The liver and spleen can be percussed. An enlarged liver is called hepatomegaly. Dullness, heard in the left anterior axillary line, indicates enlargement of the spleen, splenomegaly. You never do deep palpation on the spleen, okay? It's not in your scope of practice for nurses. So another NCLEX question, while performing an abdominal assessment on a client, the nurse notes rigidity over the left upper quadrant, okay? Which GI disorder would the nurse anticipate? And the answer is peritoneal inflammation. Abdominal rigidity is a potential finding of the nurse generalist during light palpation. This finding may cause the nurse to anticipate peritoneal inflammation. It's not gastroenteritis, it's not intestinal obstruction, okay, and it's not paralytic ileus. So psychosocial assessment, we have remembered that patients are often reluctant to discuss elimination problems, which may be very personal and embarrassing. And the interview focus is on whether usual daily activities have been interrupted or disturbed. Stress has been associated with the development of exacerbation of irritable bowel syndrome. We're going to talk about this later. We have a good correlation with anxiety and depression and other GI disorders, okay? If patients are diagnosed with cancer, it's likely that they will experience the stages of the grieving process. And then when we come back, we are going to talk about the diagnostic assessment and also the imaging. Thank you so much, and stay tuned for part 2 of assessment of the gastrointestinal system.